Chronic pain conditions are believed to be caused by somatosensory cortex reorganization that causes an increase in pain severity. This is based on previous studies whose results show that the CRPS participants had a higher level of pain severity as well as a reorganized S1 region compared to their non-CRPS counterparts. This created the basis of the research questions discussed throughout this study, which were: is MAP reorganization in the S1 region related to pain severity and upper limb disability? And does CRPS reorganize the primary somatosensory cortex? Chronic complex regional pain syndrome is a disorder that causes severe and continuous throbbing pain due to the abnormalities in the central and peripheral nervous system. These abnormalities inflict unnecessary inflammatory responses to non-existent pain. CRPS is uncommon and usually is caused by a heart attack, complication of a surgery, or after a severe injury. Chronic complex regional pain syndrome is treated by trying to restore sensory motor representations in the S1 region for the affected limbs in order to decrease pain severity and limb disability. These treatments were developed based on previous studies that suggested that CRPS causes reorganization of the S1 region in the brain. One experiment that specifically inspired this study stated that CRPS hand in the S1 region has a smaller cortical representation than a healthy hand. Despite their findings, the data was incomplete and obtained using low spatial resolution imaging. Because of those experimental flaws and more modern imaging methods, this study revisits the idea of CRPS causing reorganization of the S1 region in the brain. Based on previous studies, a hypothesis was developed stating, by using more modern imaging methods to obtain a higher spatial resolution, the reorganization of the somatosensory cortex will demonstrate an increase in the pain severity and disability of the affected limb in chronic complex regional pain syndrome of the hand. In different locations of the S1 region, therefore, it is predicted that the magnitude of change in pain severity should increase following changes in location in the somatosensory cortex during periodic stimulation of different portions of the healthy hand and the CRPS affected hand. To test this hypothesis, an experiment was developed in which 40 participants, 20 of which were diagnosed with unilateral CRPS in the hand, and 20 participants, which were healthy controls, participated in an fMRI study. Prior to the fMRI testing, pressure pain thresholds using a pressure algorithm on two sites of each hand were subjectively measured on a scale of 1 to 10, with 10 being the most painful. Then the participants were involved in a periodic stimulation of their homologous fingers of the right and left hand simultaneously. The intensity of the pain in the hand was rated by participants before, during, and after imaging, as well as over the next 48 hours and 7 days preceding. Meanwhile, the fMRI was developing a map of the cortical somatosensory locations in relation to pain severity. These maps were evaluated in both experimental groups by evaluating the phase angle of a given volex during each stimulation to create a phase-encoded map to reveal the spatial preference of the cortical neuropopulations in the S1 region. We controlled for individual differences in brain morphology by inflating each participant's cortical surface into a sphere and aligning it with an average spherical cortical surface using the free surfers tool. The results showed, in relation to CRPS and subjective pain severity, that participants with CRPS reported high pain ratings in their affected hand during their scan, as well as over the next 48 hours and 7 days. This is demonstrated in Figure 1 to the right. However, the CRPS participants' pain ratings for their unaffected hand showed no statistical difference from their healthy counterparts. This is significant because it confirms that CRPS is unilateral and does not affect the other undamaged limbs. The data also shows that there was no evidence for a difference in the S1 regions between CRPS participants and healthy volunteers. A single subject phase map demonstrates somatosensory cortex activity in the D4 region for the ring finger in all three experimental groups. When a pain stimulus was recognized in the middle finger, the D3 region would light up in all three experimental groups. Moreover, when the index finger experienced pain from the stimulus, the D2 region in all three subjects types would show activity. Finally, when the little finger was stimulated, the D1 region of the somatosensory cortex would demonstrate high levels of activity in all three subject groups. The activation of all of these regions is demonstrated in Figure 2. When an average of all the data was grouped together into 3 categories, the control, right-handed CRPS, and left-handed CRPS, the results showed the exact same findings as the single-subject phase maps across all participants. This is demonstrated in Figure 3 to the right. Finally, we also found no evidence for differential relations between CRPS-affected participants and control participants in hand map measures and clinical measures based on disease duration and pain severity as demonstrated in Figure 4. Based on the results, the cortical maps demonstrated that the S1 region of CRPS hand and the S1 region of the control participants are extremely similar. This statement is in opposition to the hypothesis that participants with CRPS should show reorganization of the somatosensory cortex. This is significant because it provides evidence that the somatosensory cortex reorganization does not appear to be directly related to pain severity or upper limb disability. When revisiting the previous evidence with the data from this study, their use of low spatial resolution imaging makes it more difficult to determine the neurological correlation between S1 reorganization and CRPS. Because of modern imaging, our study was able to gather complete data with conclusive visual images of the brain's S1 region in relation to CRPS. Moreover, previous studies used Euclidean measurements to develop cortical maps. However, Euclidean distance measurements provide indirect and incomplete evidence between the activation of the S1 regions and its supposed reorganization. Also, Euclidean distance measurements can be inaccurate because they disregard that the cortical surface is not actually flat. Our study was able to overcome these weaknesses from the previous studies by reconfiguring the activation maps onto a reconstruction of the flattened cortical surface, and by using the phase mapping technique to reveal the spatial preference of cortical neuro-populations within the somatosensory cortex. Overall, previous studies' methodological issues can affect the accuracy and validity of their data, where this study improves upon them to produce more conclusive evidence for the argument that CRPS does not cause reorganization of the S1 region. Based on the data that was collected, current treatments for CRPS, such as sensory discrimination training and mirror training that is aimed to reduce pain by restoring the somatosensory cortex reorganization, may offer clinical benefits, but it is not actually restoring the somatosensory cortex because there is no difference between the S1 region of a healthy participant and a participant with CRPS based on the results of this study. Therefore, this study challenges the current treatments for CRPS and their true effectiveness. Overall, this study demonstrates that the somatosensory cortex is more stable and resistant to alteration or reorganization than what was originally believed. In conclusion, this study determines that CPRS participants and control participants show similar somatosensory cortex organization with similar activation of their D4, D2, D1, and D3 regions within the somatosensory cortex for each individual finger, no matter the health state of the individual participant. However, this study also demonstrates inconsistent subjective pain severity scores. Irregularities may ensue in the somatosensory cortex due to excitability changes, morphological, and connectivity changes. Therefore, one of these specific changes could be the reason for the different subjective pain scores. However, somatosensory reorganization is not an explanation for pain severity or upper limb disability in CRPS patients. Overall, these findings challenge previous studies and imply a need for a new method of CRPS treatment. Overall, this study is the most complete and up-to-date characterization of the somatosensory cortex and CRPS hand. However, in order to improve on this study, we must consider that the phase mapping method we used was not able to evaluate the level of overlap between finger representation in the S1 region. Therefore, future studies should use randomization stimulation to evaluate the overlap between individual finger representations. Furthermore, longitudinal studies should be performed to determine how the cortical map changes over time within CRPS patients, as well as evaluate the changes to sensory motor function for these individuals as time persists.